Good morning, everyone. It's now 11 o'clock, and we are going to get started with our webinar. The Mountain Plains Prevention Technology Transfer Center at the University of Utah is excited to welcome you to our 5-part webinar series, Scope of Prevention Along the Continuum of Care. Before we move on, I'd like to go over a couple of housekeeping announcements. A recording of this webinar will be posted on our website at pttcnetwork.org/mountainplains. The slides in a PDF format will also be available on the website. And for those of you interested in a certificate following today's webinar, please email us at mountainplains_pttc@utah.edu. We will be happy to provide you with a certificate if you need one. We are an approved NAIADAC provider. And for all other licensure and credentials, please apply directly to your board. All participants have been muted today, and we encourage you to use the chat feature for questions and messages. You'll see in your chat right now that we've posted a link to our GPRA evaluation. It's really important that everyone that participates completes that. So you're welcome to open that now, or we will also be posting that at the end as well. The purpose of this webinar series is to discuss strategies and interventions used to prevent substance use, decrease risk if substance use has already occurred, as well as to discuss strategies for preventing relapse after treatment or during maintenance and recovery. Components of the Institute of Medicine's, or IOM, Behavioral Health Continuum of Care model will be highlighted and discussed throughout this series. In this series, we want to highlight that prevention can occur along the continuum of care, including during treatment and maintenance/recovery. Before we dive into IOM's Continuum of Care model, we want to acknowledge that some of you may be familiar with slightly different prevention models, depending upon the settings you work in. For those of you who participated in our last webinar series, we discussed some of the different prevention frameworks and models. For example, many of you are familiar with SAMHSA's Strategic Prevention Framework, which is really more of a comprehensive framework or planning process to prevent substance use and misuse. However, some of you may also be familiar with the prevention triangle, which is often used in schools and other educational settings. We want to point out that all of these models are complementary rather than exclusive. Many of you may be familiar with the IOM's Mental Health Intervention Spectrum model, which was published in 1994 and offers a framework for addressing behavioral health, including substance use disorders. This model begins with promotion, then prevention, treatment, and maintenance/recovery across the continuum, while recognizing that promotion also occurs across the entire continuum. Today's webinar will focus on universal prevention, and other webinars in this series will focus on other components of the IOM continuum. It is my pleasure to introduce our presenter today. Alexa Wrench has a BS in Health Promotion and Education from the University of Utah and is a certified health education specialist. She began her work with Volunteers of America Utah in 2014 as a prevention specialist, facilitating life and social skills programs with youth and families. In 2015, she became the Director of Prevention Services, overseeing the implementation of 7 evidence-based programs in Salt Lake County schools, after-school programs, and community centers, including a one-to-one youth mentoring program. In her role, she guides evidence-based practice in prevention, creates partnerships to support the implementation programs, and contributes to universal prevention efforts through her work with several community coalitions. Welcome, Alexa.
Thank you so much, and thank you to everybody who is joining us today for our webinar. I'm very excited to dive into universal prevention with you. Before we get started today, I want to just give a disclosure before my presentation. The prevention curriculums that we're going to discuss in our webinar are the property of the program developers and not of Volunteers of America Utah. My organization has purchased these curriculums for use in our Utah community. So I want to orient us today with 3 key points that we're going to cover throughout our webinar. These key points are going to give you a roadmap for what we will discuss. First, we're going to define what is universal prevention. Next, we will talk about what model can be used for choosing evidence-based interventions when you are a prevention services provider. And then we will discuss what component of the planning process is really essential for effective and sustainable programs. So before we jump into discussing universal prevention, I'd like to give you a quick overview of the organization that I work for so that you can have a basic background of the experience that I'm speaking from today. Volunteers of America is a national nonprofit organization that started in 1896 with the mission to go where we were needed and to do what comes to hand. So there are currently 35 affiliates across the United States who continue the spirit of that mission by providing services and programs that address the needs specific to their local community. In Utah, Volunteers of America provides services that address homelessness, addiction, mental health. I am the Director of Prevention Services at Volunteers of America, Utah, and the goal of my programs is to provide youth and families with opportunities and skills that can prevent substance abuse and violence in our larger community. So I manage a team of professional prevention specialists who provide evidence-based programs for youth and families, specifically in Salt Lake County. We currently use 5 evidence-based curriculums across the continuum for universal, selective, and indicated populations. And I also oversee a one-to-one youth mentoring program that employs professional staff and then also recruits volunteer mentors from our community. So let's start at the very beginning today with the question, what is universal prevention? Universal prevention refers to approaches that are designed for an entire population without regard to individual risk factors within that population. So the entire group shares the same general risk for substance use, and although risk may vary greatly among individuals, universal prevention strategies are delivered to the entire group without prior screening, because the entire population can benefit from the intervention. For today's webinar, I'm going to discuss an approach to universal prevention using my programs as a model. What I'm going to answer for you is, what does universal prevention look like in practice? All of the programs that my organization provides are outreach, meaning that we create community partnerships to implement the programs in schools, in community centers, in housing sites. Essentially, we meet people where they are. We provide universal prevention programs in 2 contexts, school-based and community-based. And I'm going to walk you through what these services look like and then discuss some of the differences between universal prevention in these different settings. So starting with school-based universal prevention, we provide 2 programs currently in schools, Botvin Life Skills Training and All-Stars. We have partnerships with 2 districts here in Salt Lake County to implement these programs in full classrooms during the regular school day. Many of you might be familiar with Botvin Life Skills Training. It's one of the longest standing and most awarded evidence-based programs in the world. They have sites all over the world. My organization has been implementing it for over 20 years. This program is designed with a core curriculum for middle school students and 2 booster curriculums that are taught in the years subsequent to the core that are meant to reinforce the skills taught. Through our district partnerships, we have historically been able to provide the core in 6th and 7th grades and then follow up with those same students the following year with the booster curriculum. We've had to modify that implementation within the last year because starting last school year, the Utah State Legislature actually mandated that bot-fin life skills training be taught as part of the health curriculum in our school system. So the state set aside funds for the program, and health teachers in 7th, 8th grades or 9th, 10th grades were trained to use the core curriculum as part of their health instruction. Since teachers now cover the core curriculum, we had to modify our implementation. So now we work with several schools to provide the 8-session booster in 7th, 8th, or 9th grade health classrooms that have already received the core program. Our sessions are provided weekly, and they last for about 45 minutes, a typical class period. And the topics covered in the booster include decision-making skills, stress management, communication skills, and skills for resisting negative peer pressure. Our second school-based universal prevention program is called All-Stars. This is a 12-session program that we teach weekly in 6th, 7th, and 8th grade classrooms. Sessions are 45 minutes long as well, typical classroom period, and the skills taught cover goal setting, healthy decision making, and peer resistance skills. We currently provide one universal prevention program in a community setting called Guiding Good Choices. We partner with Midvale Community Building Community, or Midvale CBC, as you'll hear me refer to it, which is another local nonprofit serving the community of Midvale, Utah. Guiding Good Choices is a 5-session program for parents that have children between the ages of 10 and 14, and it teaches skills for effective family management and talking with your teens about drug use in particular. The 2-hour sessions are provided weekly in the evening, and we do that at Midvale CBC Center. So planning for evidence-based universal prevention in the school and community context can be different. In schools, the target population is really defined by developmental age. The interventions target youth at a specific developmental stage with the skills that are relevant for that age group. So there's often less input from participants themselves about what those interventions are. Those are really determined by parents, school counselors, school administration, and the provider. In my experience with school-based prevention, you really have much more of a captive audience, right? Students don't have a say whether or not they're participating in the classroom program typically. So your engagement techniques really just focus on keeping attention of your participants. In a community setting, however, the target population for universal prevention can be defined by a multitude of factors. Maybe a community center, a common culture, common experiences, perhaps the life stage of those individuals. Community-based prevention really requires input from the community itself to create buy-in and to support cultural competency. So there are also significantly more barriers to providing community-based prevention. There needs to be a greater emphasis on creative recruitment and engagement strategies because this prevention is about bringing people in. What these two contexts have in common, though, is the need for strong partnerships between the provider and the community being served. And you're going to hear me refer back to this principle throughout our time today. So how do we get here? The structure of our services and the programs that we have selected are not arbitrary. There's a rationale behind what we choose to provide and essentially how we choose to provide it. So during the rest of our time, I'm going to walk you through how and why we make these decisions as an organization. My agency uses a model called the Strategic Prevention Framework that directs prevention interventions in our community. I'm going to go over this framework in detail. So for those of you who are not familiar with this model, my hope is this will bring you up to speed on the basics of the process that we're going to discuss with our time today. And for those of you that are familiar with it, this will hopefully be a very concise review for you. The Strategic Prevention Framework is a planning model from the Substance Abuse and Mental Health Services Administration, or SAMHSA, and it supports coordinated, comprehensive, and data-driven planning and accountability in the planning process. So basically, it's a roadmap for evidence-based decision-making. You'll notice in the diagram that there are 5 stages of the SPF model, with assessment at the top in red, followed by capacity, planning, implementation, and evaluation. You'll also notice that the framework is laid out in a cycle to demonstrate how it's an ongoing process. It is designed to be long-term and evolutionary in nature, and the resulting plan should build on knowledge and your experience over time so that you can see measurable outcomes and system improvements. In other words, this process is designed to ensure that the decision-making steps are always improving. During this first stage of assessment, we identify what is the problem. We create a profile of the population needs, what resources are available, and determine the readiness of the community to address those needs and gaps. Next, we move into capacity building, during which we identify and mobilize resources that are going to address the needs of the population. Those resources refer to both financial and human resources. Next, planning is where we develop a comprehensive strategic plan based on the needs assessment, followed up by implementation, where we actually put that plan into action, implementing the evidence-based strategies that we've planned for. The last stage before we cycle back around is evaluation. This is where we monitor and evaluate, and then sustain, improve, or replace aspects of our implementation based on what the data is telling us. These 5 stages are guided by 2 principles, cultural competency and sustainability. Cultural competency refers to the ability to interact effectively with members of diverse groups, and sustainability is the process of developing funding streams that are outside of grants and building an adaptive system that can maintain the long-term results that you're desiring in the community. These principles are integral in each stage of the framework to creating truly effective interventions. For me, cultural competency is really the most important guiding principle of this process. Not only do we have an ethical responsibility to serve our diverse communities effectively, but it's also my belief that if cultural competency is not paramount in the planning and implementation of prevention services, then the community is not really benefiting from them. What I mean by this is that while there are common cultures, each community is unique. And at the end of the day, if services aren't relevant to, realistic for, and really resonating with the community you're serving, then it doesn't really matter how quote-unquote evidence-based the intervention is or how many awards it's received. The community is not benefiting from it. We're going to come back to the principle of sustainability towards the end of our time today. For me, sustainability can be a bit more elusive in the planning process if you are a provider that's maybe outside of your community. I will go into more detail about that later, and I will share with you some of the aspects in the planning process that we've seen contribute to sustainability. So that's a quick rundown of the strategic prevention framework. The next question we're going to explore today is, what does this actually look like in practice? So I'm going to walk you through how my organization uses this framework to select the programs that we implement, and I'm going to use Guiding Good Choices, our community-based program, as a model. The goal of this exercise is to provide you with a real-world example of decision-making around evidence-based prevention in the community. So I want to give you a little background first on our history of community-based prevention. We've partnered with Midvale Community Building Community, or Midvale CBC, for the past 10 years to implement a multifamily prevention program that serves Spanish-speaking parents and their teens. The goal of this intervention has always been to improve family communication and to provide skills for effective family management. Historically, we have used a locally designed curriculum that's been evaluated on an ongoing basis here in our community. But the decision was made earlier this year that we needed to reevaluate those services and move towards a more established evidence-based curriculum. This happened to coincide with the renewal of our county contract that also funds this project. So what you're going to see today is really our second time around the cycle of the strategic prevention framework, right, where we're building on past experience to reevaluate ourselves. We began this process earlier this year with the community already identified, significant knowledge and experience with our target population, and an idea of the funding that would be available to us. So where do we start? While the strategic prevention framework begins with the assessment stage, which is using data to identify areas of need, I found that in practice it often begins with some capacity building, particularly when we're looking at community-based universal prevention. This early capacity building is really driven by the questions: what resources do we as a provider have to work with? Which communities do we realistically have access to? And how ready is the community to participate in prevention? In a perfect world, we could look at all the local data, identify the community in most need, target services to address their needs, have access to flexible funding, and the community would show up enthusiastic and ready. But in reality, many programs are limited by their funding, which often determines service areas, target populations, even evidence-based strategies, and by the communities that the provider can realistically reach. So for those of you starting this process from scratch, a logical jumping off point is to identify the community that you want to serve. Ask yourself, which communities do you already have access to, or could you gain access to through partnership? So here is strong partnerships. This is going to come up a lot today. Strong partnerships are an essential component of this process that make community-based prevention truly successful and sustainable. Community-based prevention is difficult. It often feels like we're trying to sell medicine to healthy people. By that I mean is you know and the recipient knows it's important to have, they're going to need it, but individuals have a hard time justifying the cost if there doesn't seem to be an immediate threat or an immediate benefit. So partnerships within the community can help solve the problem of buy-in and community readiness. If a or organization within the community gets behind prevention, the community is more likely to see the value and be willing to participate. So for that reason, I think that capacity building is really the best place to start. In our case, we were reapplying for funding to sustain services we were already providing. So we knew the community we had access to, and we already had community buy-in. What we were trying to decide was what interventions were we going to use. Our longstanding partnership with Midvale CBC is based on a shared vision for our community. We want healthy youth, healthy families, and access to services and resources for those who are traditionally underserved. Our partnership has allowed both of our organizations to contribute strengths to serving the community and then to pull on the strengths of each other to create a truly strong and sustainable program. So my organization holds the grant money for this program, and we provide professional staff with the training and the experience of implementing evidence-based prevention programs to facilitate the curriculum in our Midvale community. You could say that we were the catalyst for these services or this program. By partnering with Midvale CBC, though, we were able to gain the trust of the community and have community buy-in for prevention. Midvale CBC tackles recruitment for the program, and they provide professional staff who can support cultural competency in our program delivery. So we've outlined our partnership in a Memorandum of Understanding, an MOU. This was important to us because community-based prevention requires strong partnerships, and we felt it was really important to have a clear understanding of the relationship and responsibilities between us and Midvale CBC. So once we've laid a foundation with some capacity building through community partnerships, the assessment stage can begin. During this stage, we answer the questions: what are the issues for our community? What does the data tell us the community needs? What does the community feel they need? And what services are already available? Are they being accessed? Why or why not? Cultural competency requires that we start by seeking to understand who makes up the community that we're looking to serve. Understanding the characteristics that define a community is essential when you're designing ethical and effective interventions. So we needed to examine some questions. What cultural or social characteristics define our community? What do they value? What do they want? And what's the level of education and skill of members of the community? So through relationships in the Midvale community and years of experience working with Midvale families, we were able to define key characteristics and values of our community. Midvale CBC serves a largely Hispanic and Spanish-speaking family, but individuals actually represent a broad range of Hispanic backgrounds. So while there's a common language, there's not necessarily a common culture. What we do find unites a lot of people, though, are the generational and cultural differences within their family structures. Many of the children in our programs are only first or second generation Americans. Therefore, they often don't share a common culture with their parents. So not only are there the typical generational differences between parent and child, but there are stark cultural differences that are evident in expectations, values, communication styles that result from growing up in different countries. Despite these differences, though, families are very tight-knit. Parents value education highly, even though many have never received a formal education or been educated in the United States. They want their children to do well academically, and they want them to find lucrative work. Most parents in the Midvale community work, and their children are expected to contribute by helping at home or helping with younger siblings. We found that family management styles are typically based on the belief that what a parent says goes without question, and that there's not a lot of room there for differing opinions or discussion, particularly discussion of feelings with your children. This kind of knowledge we've gained from years of experience. If you are starting this process from scratch, this knowledge comes from strong community partnerships, right? Finding advocates within the community who can really speak to the culture and the expectations of the people that you're looking to serve. So after we described our community, we began to review current data available to us, and that data can come from national sources, local health departments, schools, police departments, youth surveys in your community. The goal really being to create a picture of health behaviors and outcomes related for us to substance abuse in the community. That way we can target universal services appropriately. So we assess data from two primary sources, the SHARP survey and qualitative feedback from parents we've already served at Midvale CBC. Here in Utah, every 2 years, the state administers the Student Health and Risk Prevention Survey, SHARP survey, to students that are in 6th, 8th, 10th, and 12th grades. The survey measures youth substance use, mental health, and risk and protective factors, giving us an incredibly accurate picture of youth health behaviors in our state. The data can then be filtered by county, by city, by school, by demographics. Looking at our most current data, which was from 2017, we created a profile of youth substance abuse in our Midvale community. We found that overall, an average of almost 20% of teens were reporting early substance use. We saw that tobacco, particularly in the form of e-cigarettes, marijuana, and alcohol were the drugs of major concern in our community. And we also observed that substance use begins around 10% in the 6th grade, and it increases significantly as youth move through middle school and high school. The SHARP survey also highlighted some of the risk and protective factors that we needed to address in our community. About 32% of teens reported a lack of family management, so that refers to parental monitoring, accountability, and almost 12% felt that their parents would not care if they were using drugs, with the highest rate starting in 10th grade, around 20% of teens reporting that. Also importantly, we noticed that only about 40% of teens felt that drug use was a risky behavior, so there is a low perceived risk of drug use in the Midvale community. Prevention science tells us that youth need support to develop emotional and social coping skills, and they also need pro-social involvement with peers and with adults to reduce their likelihood of substance use throughout their lifetime. When youth are bonded to their community and they experience healthy boundaries, they're more likely to find value and achievement and participate in their community in appropriate ways. So the combination of healthy relationships and clear standards make high-risk decisions like substance use less appealing to youth because they're contradictory to community norms and to their personal values. Our other data source was parents in the Midvale CBC community who have told us what they feel they need for their families. We have gathered that over 10 years of working with this community. Parents in Midvale consistently tell us that they value family relationships and they want to stay close to their children as they grow. They're very worried about the prevalence of substance abuse, and they don't want their children using drugs, but they often don't know how to talk to them about issues like drug use. If you're starting from the beginning and you don't have prior access to this community, this kind of qualitative data can be collected through community surveys, focus groups, and the insight of key leaders that you create partnerships with. The final stage is assessing barriers. What are the barriers that this community might encounter that will affect their ability to receive services? In Midvale, working parents means that programs needed to be provided in the evening so that the family can attend. And many families have multiple children, so evening programs are going to cut into family responsibilities and dinner time. So after we built capacity to serve the community and conducted an assessment to outline where we needed to go, we began the planning stage. Our assessment showed that to address youth substance abuse, we needed to increase family management skills and the perceived risk of drug use. Based on our experience in Midvale, we knew that parents were also looking for opportunities to increase family communication and bonding, and we knew the curriculum needed to be provided in Spanish for families. We also understood the learning styles of the community. Most favored interactive learning opportunities. They wanted to practice skills, and they didn't feel comfortable with too much reading or writing, so it needed to be a discussion-based interaction. Therefore, we explored evidence-based registries for programs fitting our needs. I'm going to highlight a few options for you that you may or may not be familiar with. There are many evidence-based registries. These are the ones that we typically turn to. The first is Blueprints for Healthy Youth Development, which is an initiative out of the University of Colorado. It applies rigorous standards that assess a range of prevention interventions, and they list programs as promising or as model. In order to qualify as a model program, there must be positive findings from 2 randomized trials or results from 1 randomized and 1 high-quality quasi-experimental study. So model programs also need to show sustained effects for at least 12 months following the intervention in one of those 2 studies. This database has one of the highest standards for evidence-based practice, and it's an excellent resource when you're looking for programs that truly work. The second I want to point out is the Office of Juvenile Justice and Delinquency Prevention, OJJDP, their model program guide. This resource allows users to search prevention programs by a variety of outcomes, so academic skills, truancy, bullying, substance use, or by type of intervention, so classroom curriculum, cognitive behavioral training, and school-wide strategies. The model program guide will provide you with a summary of empirical evidence in a specific problem area, and then it produces a list of effective programs. Finally, the Results First Clearinghouse database is an online resource that brings together information on the effectiveness of different social policy programs from 9 national clearinghouses. It's sort of like the Travelocity for evidence-based practice. So you can search a list of programs targeted at a specific outcome as well as their rating in evidence-based practice. So we searched these resources for substance abuse prevention programs for teens and parents that have been shown to increase family bonding and family management skills and ultimately delay the onset of youth substance use. The next step was to assess the programs on our list for feasibility in our community. So we answered the questions. In what context was the program evaluated? What is the cost of the program? Is there training required for facilitators? How long and intensive is the program for participants? And are there materials available, and what do they cost per person? So if a program was only evaluated in a largely white, middle-class, suburban neighborhood, it was not going to be ideal for our community that we were going to serve in Midvale. We also had to find a program that was cost-effective, that would fit the funding we might be able to access. Since my staff are professional prevention specialists with decades of experience between them, I really felt that it wasn't entirely necessary for them to attend a program developer's training. So we were looking for a teaching manual that was comprehensive and well-structured, as well as a developer that did not require a training as part of the curriculum purchase. In the past, we have provided an 8-week and a 6-week program for Midvale families at CBC. Families seem to trail off over that 8-week program, so we knew we needed to keep it on the shorter end. So we got to the Guiding Good Choices program. This program has received over 9 evidence-based recognitions, including Promising from Blueprints for Healthy Youth Development, and Exemplary 1, which is the highest rating from the Office of Juvenile Justice and Delinquency Prevention. It's a 5-session skills training program for parents and their middle school age children that's held weekly in 2-hour classes. The primary objectives of the curriculum are to enhance family management skills for parents and to help delay the onset of youth substance use. The sessions are discussion and activity-based, using a lot of multimedia instruction, and adolescents are required to attend one of the sessions that teaches peer resistance skills with their parents, while the other 4 sessions are just for parents, and they cover topics such as risk factors for adolescent substance use, strategies for enhancing protective family processes, effective parenting practices, family management, and then including your child positively in the family process. So this curriculum costs roughly $1,000 and is available in both English and Spanish. And the initial purchase was going to include all the materials that we would need for implementation this year. After selecting the evidence-based strategy that we were going to use, we had to create a plan for how we would implement it with respect to the community barriers that we'd identified. For those of you in this field, I'm sure you're well aware that recruitment for community-based programs is a task that requires immense energy and diverse strategies. This is where strong community partnerships are really important. So we are very fortunate in our partnership that Midvale CBC not only hosts the program at their center, but they also tackle recruitment for the program. An unfamiliar and uncomfortable service location can be a barrier to bringing people in. So families are recruited for Guiding Good Choices from those that are already accessing services at Midvale CBC. So not only are they recruited by familiar and trusted faces, but the center is a really easily accessible location that they're familiar with. Next, oldest trick in the book to bringing people in the door, providing food. Especially since the program is held in the evening, we needed to plan for providing a meal to participants each night to cut down on that barrier. Finally, the Guiding Good Choices program is a parent education program, but it's pretty hard to get parents in the door for evening programs if there's not an easy and a free option for childcare. So we address this barrier in a unique way at our organization. Since the program targets parents with children ages 10 to 14, we asked ourselves, how can we provide these 10 to 14-year-olds with opportunities to practice skills that are related to the ones their parents are learning? As I mentioned, here at Volunteers of America, Utah, we currently use 5 evidence-based curriculums, so we do have access to interventions for youth between the ages of 10 and 14. We decided that while parents are participating in the Guiding Good Choices program, their 10 to 14-year-olds could participate in a youth group using another one of those curriculums. So that just left the need for childcare for any siblings that were under the age of 10. So in planning, we were looking at providing a dinner. We knew we needed 2 facilitators and a child care worker in order to effectively implement the program. So the next stage we move into is implementation, which is putting the plan into action, where we actually make it happen. Our implementation of the Guiding Good Choices program will begin again in October. So we're kind of on the end of the planning phase where we're getting all of our logistics in order to be ready to start. So based on our plan, the Guiding Good Choices program will be held at Midvale CBC 3 times during the upcoming year. Each cycle will consist of 5 2-hour sessions that are going to be held weekly from 5:30 to 7:30 p.m. in the evening. We determine that time frame because that gives working parents enough time to get off work and to get to the program with their children. Participants are going to be recruited from the Midvale CBC community, and they must have 1 child between the ages of 10 and 14 to be eligible, but they can bring all their children to the program regardless of age. Dinner will be served from 5:15 to 5:45 each night, and then after dinner, children under the age of 10 will go with the daycare worker. Youth ages 10 to 14 will participate in the separate youth group, and parents will participate in the Guiding Good Choices lesson. As I mentioned earlier, the session number 3 of each cycle is a joint session where both the parents and the youth participate together to practice peer resistance skills. Finally, evaluation. So implementation and evaluation really go hand in hand. Evaluation is the ongoing process through which we measure success and we continue to grow and improve our strategies. As an organization, we conduct both process and outcome evaluations of our programs. And what I've walked you through so far is the result of the last 5 years of evaluation that we've conducted. So we evaluate the process of our implementation through attendance and fidelity monitoring. Are people showing up to the program? Are they completing the program? If not, why? We measure the quality of implementation by monitoring facilitators while they're providing services. Are they covering the curriculum adequately? Are the participants responding to the teaching techniques? If not, what can we modify to improve those interactions with participants? These process evaluations are conducted each cycle of the program and reviewed with program staff and with our partners. We then evaluate outcomes through pre- and post-testing of participants and through feedback surveys. Pre- and post-tests help us measure if participants are walking away with the changes in knowledge, attitudes, and behaviors that we expect from them. And feedback surveys give us really important insight into participants' experience during the program. What worked for them, what did not. As I mentioned earlier, if participants are not responding positively to the material, it doesn't really matter how quote-unquote evidence-based the intervention is, they're not taking away those core lessons. Our outcome evaluations are analyzed on an annual basis and inform planning for the next year. So let's circle back to talk about the principle of sustainability and how it plays out in this process. Sustainability is a complicated principle to address as a provider because for me the bottom line is if the current funding stream is no longer available, it's really difficult for our programs to be sustainable outside of another easily accessible funding stream. So planning for sustainability for me as a provider is about focusing on those strong partnerships that create community buy-in and demonstrating our positive outcomes over time through an evaluation process. Sustained positive outcomes demonstrated through data is the best way to continue to fund programs, especially when it's backed by community enthusiasm and active participation. A provider can take those results and then move to other funding streams or find creative ways within the community to fund those programs. So I think we have a bit of time now for some questions. I'm wondering, Rory, if you can give me some help with the chat box, and I can't see it on my screen, so if you could read out some of the questions that participants might have, and I can answer them as best as I can.
Yes, I'd be happy to. So Joy from Sioux City, her response was, I love evidence-based curricula, but our biggest obstacle is getting the large block of time in the classroom. Here in Sioux City, health classes are now elective rather than required. So how do you get the time from teachers?
That's a really great question. So, and I'm going to sound very redundant, but I'm going to go back to it really starts with strong partnerships and an understanding from the top down within the systems you're looking to serve about the importance of prevention. So not only do we have partnerships with classroom teachers to provide the program, we are also working with school administrators and district personnel who are all bought into the idea of prevention. It takes a bit more time to establish those relationships within a school district in particular, but the best place to start is from the top, finding a key advocate within the district who really understands the importance of prevention and what that means for the students. So here in Utah, I think that there is a much larger understanding now of the importance of prevention and how that interacts with academic success. So we have departments within our districts that focus solely on prevention. And their job is really not only to choose strategies for district students, but to educate school administrators, classroom teachers, parents about the importance of providing these life skills and social skills for youth so that they can be truly successful in the classroom. So to answer your question, Joy, I would be the biggest advocate for prevention in your community that you can. Find people within the school district or within schools who understand the goal of your program. And then work with teachers to understand that, yes, you are providing us with a chunk of time that could be given to core classes, but really what we're here to support is the academic success of your students. And I have found that the majority of teachers are on board with that, and the ones who aren't are typically swayed by other professionals who do understand that. Thank you so much for that question.
Do we have any other questions from participants? Feel free to type it into the chat feature. Alexa, let's just give it a couple minutes. Yes, and I can go ahead and answer this question. It says, will we have access to the slides? And the answer to that is yes. As always, we post a recording of this webinar as well as a PDF of the slides and on our website. And so you'll be able to find those there, and that's pttcnetwork.org/mountainflames. The next question for you, Alexa, is sixth grade the earliest age for prevention?
That's a wonderful question, and no, it's not. So prevention is better the earlier it begins. There are advocates within my really believe that prevention starts in utero, right, with mothers before they have children. Prevention with younger children looks different than prevention in sixth grade and prevention through middle school and high school. We do provide prevention for students that are in second through fifth grades, and what those programs typically look like are social skill building programs. So we really are targeting, do kids have the skills to communicate their feelings effectively? Can they identify their feelings effectively? Can they relate to their peers in appropriate ways and sustain relationships, interpersonal relationships? So we don't really, with younger students, we're not really talking with them about the issues that we're looking to prevent. We're more focused on the risk and protective factors that we know can affect substance use later in life. When we start working with students in 6th grade, we're still focusing on those risk and protective factors, but we're also adding in a component of knowledge for those youth of here are the risks of certain behaviors, and here's what we'd like to avoid. So no, prevention does not start with 6th grade. Our classroom-based prevention starts in 6th grade. My organization itself provides selective and indicated prevention services for younger students.
Thanks for your answer, Alexa. The next question, actually, probably a perfect. You just talked about it a little bit. Is what content might be different for a universal population versus a selected or indicated population?
Yeah, that's a great question. So based on the programs that we provide, universal prevention programs really contain general social skills, right? Skills that we can all benefit from and that mitigates the risk that we all face of substance use. So that looks like effective communication, identifying feelings and expressing feelings appropriately, especially to peers who ask us to do things that might get us into trouble. Those are very universal, overarching skills. With selective and indicated populations, we are still using those skills as a foundation, but we're taking it a step further to address, here are some things that you might be experiencing in your life. How do we apply those skills to what you've seen, right? Does that answer your question?
Yes, she said sure. And Julie, if you need additional information, feel free to, Alexa, would it be okay for her to reach out to you?
Of course, of course.
Okay, great. Another question that was posted, and I'm not sure, Alexa, that you would know this, but I will still ask you, is does Denver have this middle school program?
That is a great question. I am not aware. I'm not aware if it does or not. I don't know the answer to that. I do know there is a Denver affiliate of Volunteers of America Utah, and they, as far as I know, do not have a prevention department. But no, I'm not sure of the answer to that.
Yeah, you know, Dana, you might try reaching out to either the Office of Education in Colorado or the Department of Behavioral Health or there in OBH in Colorado to see if they might be able to help answer your question. Any other questions for Alexa at this time? Okay, well, that said, let's see here. So, so thank you so much for attending the webinar today, everyone. If you would please remember to complete our GIPRA evaluation, there is a link in the chat feature that we would really appreciate it. It's so important. And again, if you would like a certificate for your certification today, please email us. And then lastly, we record and post all of our webinars on our website. And all you need to do when you go to our website is you'll see 3 little bars to the left of the Mountain Plains navigation. Click on that, and it will take you. There'll be a link right there to the 5-part webinar series, And then also you'll see all of the webinars that we've done in the past in case you would like to go and review those as well. So again, thank you so much for attending our webinar today, and have a great day. We're going to leave the chat feature open for just a moment, so those of you, so you can click on our link. Thank you so much and have a great day.